All right, well, good morning and welcome to the Foundation for Healthcare Quality's 22nd Annual Northwest Patient Safety Conference. Over the past decade, our conference has grown from being focused on local organizations to including those across our Pacific Northwest region. And we now attract partner organizations, attendees, and speakers from around the world. Our foundation started in the late 80s to really serve as a neutral third party resource for independent review and analysis within our state's healthcare community. We have really grown as a volunteer driven neutral nonprofit to house keystone programs, including the Care Outcomes Assessment programs focused on cardiac care, obstetrical care, spine surgery, and general surgery, the BRE Collaborative, Smooth Transitions, the Administrative Simplification Program, and of course, our Washington Patient Safety Coalition, all dedicated to improving healthcare quality for everyone involved: clinicians, patients and their families, allied health professionals, executive leadership, policymakers, and future healthcare leaders in the health sciences. We gather today in a moment unlike any other. Our landscape of healthcare is shifting rapidly and not always in ways that we hoped. We are witnessing an erosion of trust in science, the defunding of research, and the politicization of basic care. Professionals are being silenced, institutions are under pressure, and misinformation is no longer a fringe concern. It is a daily reality. Neutral, nonpartisan organizations have always played an outsized role in bringing together different, often disagreeing parties to work on common priorities like quality of care and patient safety. Our world needs honest data and credible expertise to be valued, and differences in interpretation, as well as limits to interpretation, to be deliberated respectfully to reach evidence informed consensus decisions. Now more than ever, historically successful neutral groups must be sustained, where people and organizations can come together and be willing to work collaboratively toward achieving common goals, like protecting and continuously improving patient care, safety, and quality. This year's conference theme is Navigating Rough Seas, and we believe our foundation's history shows it is the right vessel with which to progress through this era's challenges. I invite you to join us in our thought provoking conference sessions. Visit our website to learn more about our activities and consider becoming a volunteer within the advocate community of members who support our foundation's many committees and program activities. So today, all presentations are being recorded. Presentation slides and speaker contact information will be available on our conference website in about 2 weeks. These will be available to all registered attendees for 1 year. If anyone missed the live conference, you can still register anytime to view the recordings and receive CE credits. The conference is approved for 14 total credit hours. To request CEs, complete the conference evaluation, which will be emailed to you after the conference. CE instructions will be on that evaluation. And now it is my pleasure to turn it over to Dr. Christina Petsas from United Healthcare, a conference silver sponsor, to introduce our first keynote speaker.
Thank you very much, Jenny. Good morning, everyone. I'm Dr. Christina Petsas. I am a family medicine physician and currently the Chief Medical Officer for United Healthcare commercial health plans here in the Pacific Northwest. And it is my pleasure to be with all of you today to put a focus on this important topic of patient safety. As a primary care physician that's practiced for the better part of the past decade in the Pacific Northwest in full spectrum medicine, meaning that I deliver babies, took care of pregnant women, and continue to take care of the aging population, that I've seen firsthand how patient-centered care that prioritizes transparency, accountability, and advocacy can lead to patient safety improvements. Now, at United Healthcare, of course, patient safety isn't just a priority, it is a foundational value that guides everything we do. As Jenny mentioned, in a complex and ever-evolving healthcare landscape, our mission remains clear: to ensure that every individual receives the care that is safe, effective, and centered on their well-being. So it is my honor to introduce Michael L. Millenson, President of Healthcare Advisor LLC, He is an internationally recognized leader in promoting the use of information to make care safer and more patient centered. The author of critically acclaimed books like Demanding Medical Excellence, Doctors and Accountability in the Information Age. He has also advised a broad range of organizations on strategy, carrying out research as adjunct faculty at Northwestern University's Feinberg School of Medicine and lectured at professional meetings worldwide. Now, National Public Radio called Michael in the vanguard of the movement to measure and improve medicine. His book inspired the first Zero Harm Initiative by the Pittsburgh Regional Healthcare Initiative and was cited by the New York Times in its editorial on the To Err is Human report. Michael also helped with the launch of the Leapfrog Group and was a founding member of the Chicago Patient Safety Forum and a board member of its successor organizations. Like many supporters of Patients for Patient Safety, he is one of its champions. Michael currently serves on the National Advisory Council of the Agency for Healthcare Research and Quality, as well as on a National Academy of Medicine workstream, examining the role of financial incentives in U.S. healthcare. Prior to starting his own firm, Michael was a principal at a major human resource consulting firm. And before that, he was a healthcare reporter for the Chicago Tribune, where he was nominated 3 times for a Pulitzer Prize. And now, without further ado, please welcome Michael Millicent as he presents Why We Still Kill Patients and What We Need to Change So We Don't.
Well, thank you, Dr. Petsis, for that nice introduction, and also for being a supporter of the group. You know, as I listened to Ginny describe your activities, in my mind, I had it all framed in place somewhere because I thought that was a great description of where we are and what we need to do in this country. So thank you for that and for your important work. To Steve Levy and all the colleagues for the invitation, and 22 years of looking at patient safety is a tribute both to your persistence and your passion. So I really appreciate being here. Now, since the meeting is virtual, I'd like to start by suggesting that we use our imaginations together. You can imagine that I'm not sitting here staring at a computer, and that instead I'm walking around a room and I'm looking everybody in the eye and I'm talking to you, and we're making a lot of personal contact. And I, in turn, will imagine that nobody is looking at their cell phone. So if we use our imaginations together, then I think we'll be okay. So what the title of this talk is Why We Still Kill Patients and What Needs to Change So We Don't. And I'm going to start with a combination of evidence and talking about frontline experience, both my personal experience and a lot of stories that are not told about patient safety, but are really important because they tell us what's really going on. And I'm going to talk about 3 formidable barriers: invisibility, inertia, and income. And then I'm going to frame creating a patient safety culture as an innovation. Right? Innovations are something that cause us to have to change the way we do things now to a different kind of way of doing things. So I'm going to talk about that and talk about, in particular, the first critical element to diffusion of innovation is comparative advantage. Why should I change? What is the advantage to me of changing? And in doing that, I'm going to provide an example of one patient safety change that was very successful, and another that's a lot more famous, but maybe wasn't as successful as people like to think. And then I'm going to close with some realistic, tough love advice for the patient safety community. It's a lot of territory. It's a lot of stories. I think that, you know, along the way, I hope we can connect them all. But as you just heard, don't worry, it's all being recorded. So why do we still kill patients? I'm going to begin to address that question with a little bit of personal history. Back in 1994, I received a grant from Robert Wood Johnson Foundation to look at how the computerized use of information was making medical care better. And I thought I really understood what was happening in healthcare. I'd been out in the front lines for a while. I'd done a lot of research work with academics. I was a journalist. And it turned out that I was incredibly wrong about what I really understood happened at the front lines of care. Now, medical error back in 1994 was largely cloaked in a professional shroud of silence, of secrecy. It was largely invisible except for a few periodic eruptions into the literature. And I'll give you an example. When Dr. Lucian Leape, who's now celebrated as one of the pioneer researchers in patient safety, submitted a commentary to the New England Journal of Medicine called Error in Medicine, it was rejected without even being sent for outside review. And he was a professor at Harvard. That gives you an example. At a lecture I just heard this morning, Dr. Tom Delbanco, who was at Beth Israel Deaconess Medical Center, talked about an article that he and some colleagues did back then on medical error at their own facility, talking about 14% of patients who had cardiac arrest died because of problems in their treatment. And he had to withdraw the article after the chair of the Department of Medicine heard about it because it was bad for the reputation of the institution. And it took another decade before they could publish it. Now, I saw some of the evidence out there and I heard some of the stories. And I put together, using crude methodology, but based on the medical literature, that there were 180,000 people who died every year from adverse events in hospitals. And that number was so large that it stunned me, it angered me, and it depressed me. And the reason it depressed me was a question that is obviously still haunts me today, is how could all the good people that you and I know, our friends, our colleagues, our family who are in healthcare, how come they are not doing everything they should to prevent medical harm? Why is first do no harm not their very first priority? So let me try to address that. Next slide, please. So invisibility. I've already mentioned that a little bit. And while we've made progress in visibility, we need to be, and I'm going to do this throughout this presentation, we need to be realistic about what our problems are. So invisibility remains far too prevalent. Last month, the former governor of the state of Illinois, Jim Edgar, died at a hospital in the capital, Springfield, Illinois. The family put out a statement saying that he died of complications from treatment of pancreatic cancer. The Chicago Tribune referred to an adverse event. But in the New York Times, which is the newspaper of record, the obit said he died of pancreatic cancer. And only after I sent them a note asking for a correction did they write that he died of during treatment for pancreatic cancer. No adverse event, no complication during treatment. So at least, by the way, adverse event is plain English. One way to make medical error invisible is the words you use to talk about it so the public doesn't understand what you're talking about. So for instance, iatrogenesis, a Greek word which sounds like what the Bible says God did in creating heaven and earth, or hospital-associated conditions, which sounds like what happens when you eat a hospital meal, right? God forbid we should say anything like harm or error. So invisibility is a real issue. Next slide, please. This is a man named Brad Schwartz, who now runs a group called Greater National Advocates. As you can see, he has a hook on his left arm, he has a stump on his right arm, and he has amputations of both legs below the knees. I didn't even know who Greg was until we happened to be going to an out-of-town meeting and somebody said, oh, there's a patient activist in your community. When I spoke to when I talked to Brad, what happened to him was due to an error in treating sepsis at a hospital that's in my health system where my wife has received treatment. I had no idea, right? And I'm an activist. So that tells you that harm remains largely invisible. And so there's no backlash to it. Second slide, next slide, please. So the next barrier after invisibility is even when we know harm happened, nothing is done about it. Inertia. You have invisibility, then you have inertia. And to me, the article that exemplifies this happened all the way back in 1955, where there was an article in JAMA entitled "The Hazards of Modern Diagnosis and Therapy." And those hazards were the fact that patients are injured and killed. But the reason they're injured and killed is because medical care is complex. It is, quote, the price we pay, unquote, for the complexity of modern medical care. I love that phrase, the price we pay, as if the author was unaware of who was actually paying the price for harm. And that attitude, though, that there's a fatalistic attitude about patient fatalities, that attitude continues to have a pernicious and persistent effect on what we're doing. Because if harm is inevitable, and all of us in patient safety have had someone come up to us and say, well, you know, they were sick and da 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 da. If harm is inevitable, then inertia is an acceptable response. Stuff happens. Now, in the 70 years since that article appeared, the world has changed in many ways. Next slide. In 1955, this is a slide of Fred Hutchinson, who was the manager of the Seattle Rainiers, a AAA affiliate of what they called the Cincinnati Redlegs, because calling them the Reds was not acceptable in the McCarthy era. That's who Fred Hutchinson was back in 1955 before he died of cancer and his brother named a cancer center after him. And yet, despite everything that's changed since 1955, invisibility and inertia still remain as stubborn barriers to physicians and hospital executives treating patient harm as an urgent issue, as first do no harm. Next slide, please. So let's document that. This is a report that came out in July of this year from the Office of the Inspector General of the Department of Health and Human Services. They found that although patient harm is common, affecting roughly 1 in 4 hospitalized Medicare patients, quote, hospitals did not capture half of patient harm events. In many cases, staff did not consider these events to be harm or explain that it was not standard practice to capture them. Moreover, quote, of the patient harm events that hospitals captured, fewer investigated, and even fewer led to hospitals making improvements for patient safety in 2025. Next slide, please. See no evil, hear no evil, fix no evil. We need to speak out in plain terms. This is unbelievable. I'll talk about this later, but patient safety seems to be an area where people in the general public don't get outraged. If you change that and said hospitals are not treating breast cancer and they don't see any harm, or hospitals are not treating heart disease and they don't see any harm, right, there would be outrage. But we seem to be an outrage-free zone, unfortunately. So the other slide that I'm going to talk about is income, right? And what's evil, when I say evil, what's evil is not someone who just makes a mistake, the surgeon whose hand slips. What's evil is the surgeon who won't take timeouts before surgery, and the administration won't do anything about it, even when nurses complain, because that surgeon makes a lot of money for the hospital, and not taking timeouts, he's more productive. That is the evil we need to call out. So next slide, please. Money talks in healthcare, and it always has. And just for fun, here's what a series of interviews with doctors concluded back in the 1950s, which the medical profession tends to call the golden age before those evil third-party payers got involved. So let's talk about what the golden age really was. And here's a quote from a report. Physicians, quote, think about money a lot. about how to increase their incomes, about the cost of running their offices, about what their colleagues in other specialties make, about what plumbers make for house calls. That's the end of the quote. And that frank assessment of medicine in the golden age came from a 1955 report by the American Hospital Association. And the public held much the same opinion, right? So you can read what's written in the journals, but then one way of looking at what the public actually thinks is going on is to look at, well, next slide, please. This is a cartoon from the New Yorker in 1959, where the doctor's attending this elderly matron back when they made house calls, and he opens up his black bag and all these dollar bills come out, and he says, "Pshaw, I grabbed the wrong bag." So what does that tell you about what was going on when that's a cartoon in the New Yorker? So let's talk about money. The first study to ever examine adverse events across multiple hospitals was done in response not to patient harm, but to rising malpractice premium rates. And it was done in California by a physician attorney named Don Harper Mills. It was sponsored by the state hospital and medical associations, and it was appeared in 1978 in the Western Journal of Medicine. And what it found was that, quote, potentially compensable events were uncommon, and lawsuits that were successful were even less so. So it's not the lawyers, it's us, but don't worry, the lawsuits aren't very successful. In other words, patient harm was not significantly harming the bottom line. Next slide, please. So now we go back to, again, a study. This one is 13 years after the Mills study. 13 years later, malpractice premiums are going up. Doctors are concerned. And in Boston, they say, you know what? Malpractice premiums are going up. Let's see if we can replicate the Mills study and look at potentially compensable events. And they look at a bunch of hospitals throughout New York State. They find out that harm is, again, extensive. And what's interesting, and I just found that in researching this presentation I didn't know, is this is done at Harvard. They wanted to look at hospitals in Massachusetts, and the Massachusetts Medical Society told them, no way are we letting you look at medical error that close to home, right? Invisibility again. But again, the way they keep it invisible is invisible because nobody writes in the medical literature, I submitted this to 3 other places and they wouldn't even send it to outside review, or they wouldn't let me look at my own hospital because then I'd lose my job, which people have. So that's the problem with, one of the problems with income. All right, let's look again, fast forward to, next slide, please. So now in 2023, Dr. David Bates at Harvard decides to look at the safety of inpatient care to follow up the medical practice study. So every couple of decades or so, we're going to look at patient safety. That's good enough, isn't it? So he actually gets permission to examine records in Massachusetts. See all the progress we've made in 30 years or so? And unfortunately, he finds harm in 1 in 4 patients, just like the OIG report did. And the research was supported, if you read the small print, the research was supported by a grant from a malpractice insurer and a risk management foundation. In other words, the literal payers of the price for patient harm. Now, while addressing patient harm, mostly when you're worried about malpractice premiums, isn't exactly a wonderful thing for the reputation of doctors and hospitals, what's far worse are the quiet decisions to turn a blind eye to harm and potential harm because it can be profitable. Not reprimanding the surgeon who's productive and doesn't quite follow the book on preventing harm, not reprimanding a surgeon or two is just the tip of the iceberg. And I want to give you some examples which don't come with slides, they just come with angst about things I've personally seen. So the first example is not long after I published my book. I was giving demanding medical excellence. I was giving a speech, and a woman came up to me afterwards and told me how inspired she had been about my book to try to improve patient safety at her hospital. So she had told the hospital administration that they had to buy computerized technology to prevent medical errors because the government now required it, which in fact was not true. The government didn't require it, but by lying, she got them to buy the technology. Second example, I was at another meeting, and the vendor of an advanced technology for infection prevention, that they could tell what kind of bacteria were at getting infections in different parts of the hospital where the bug came from, was giving a presentation, and he said that hospitals wouldn't buy his product because they thought they were making money on infections. And he actually put up a slide with a bar chart showing what different people were paying for infections, what different payers were paying the hospital. So what he did was he got a private insurer to sponsor him for a year to work at the hospital with his technology until he could prove to them that they were actually losing money from Medicare. And then it was okay to buy the technology. What's interesting about that, apart from the fact that it's awful, is nobody at the meeting rushed to the microphone and said, a nonprofit hospital would never do that. And like many of you on this webinar, you've had the experience of the same thing. You've heard people say, frankly, in meetings, we can't do that because we'd lose money. All right. Then there was the Academic Medical Center that tested a device to detect when patients recovering from surgery on a regular med-surg floor stop breathing, which as a non-physician I know is very harmful, where they stop breathing, which can happen due to a delayed release of opioids into the respiratory tract. It depresses breathing. Stopping breathing is not good for you. So the hospital found that the ICU beds the injured patients were being rushed to in order to prevent brain damage or death would be more profitable if they were available to different, more profitable patients. And based on that return on investment analysis, they bought the system. Now, if you read about their results with this system a year or two later in the medical literature, it talked about the clinical results. There was no mention of the ROI calculation that led to these nice clinical results. And by the way, what happens if you don't have patients who are waiting to use those beds? Should you let people be rushed to the ICU because it's okay to make some money? What happens if you let them die instead of being harmed? Then the beds are free. This whole economic analysis thing is not only is it morally awful, it's not even good economics. If you really want to, economics is called the dismal science. If you really want to be dismal, do a rigorous analysis. But I think that medical journals would not print an analysis that said, hey, if you let them die, no harm done. And by the way, economic harm done. While I was at the meeting where I talked to one of the nurses who makes this presentation, said this is what the customers demand, I talked to a physician who had had a patient die of exactly this problem at his hospital. So are these isolated instances? No, I could go on. But perhaps the most damning evidence is that professional journals deem it necessary to regularly run articles making the business case for patient safety. Next slide, please. Okay, so this is where I start to rant and rave because this one drives me nuts. This is the most appalling example I have ever seen in 30 years of doing this. It is an analysis of the economic benefit of preventing central line associated bloodstream infections, CLABSIs, which can be serious or even fatal in children hospitalized with blood cancer. And the study at a cancer hospital concluded that if the extra $70,000 in average costs of these kids with eclampsia, if that could be recouped by the hospital, then, quote, that could make it, and I quote, worth investing in efforts to prevent eclampsias in this vulnerable population. Okay, vulnerable population. This is an economic analysis of preventing eclampsias in 9-year-old kids on average. Now, back then, I was so shocked by this, right? I was so shocked by what he was saying that I actually reached out to the author. And the reason these articles are done, let me be clear, the reason these articles are done and printed is because people think it's necessary, because they can't just go to the administration with a moral argument and they won't get the money, as I just showed you with the stop breathing prevention. So I called up the author and I said, like, I was a researcher, right? So what was the reaction of, the hospital and the community to you writing this article? And he said, oh, it was great. They saw that there was an economic case and they did things and everybody was really grateful. Okay. So let me pause here to recap. The impact of the invisibility of patient harm can be translated to, we don't need to change. Inertia due to the inevitability of harm? Well, we can't change anything anyway, complexity. And income, we shouldn't even try to change. We don't need to change. We can't change, and we shouldn't even try. That's how we can put it really simply. And the result, really simply, is people die. That's what we're looking at when you cut through all the jargon. And how do we break through that? Well, I want to make a suggestion here that we step back, as I said at the beginning, and try a different framing, that creating a patient safety culture is an innovation. It can be complex. You have to do a lot of different things. It requires people to change, right? And so if you want people to change how we've always done things, one guide you can look to is a book called Diffusion of Innovations, a classic work by communications theorist Everett Rogers for guidance. And Rogers wrote the book because he saw changes that were, quote unquote, good for you that people didn't make. So why didn't people just change when we know that they should? So next slide, please. So Rogers links the success or the speed for any innovation with 5 characteristics, as you can see here on the slide. The first is relative advantage over what currently exists, compatibility with existing values and behaviors, lack of complexity, ability to be subjected to experiment. Can we see whether it works? Trialability, and then producing results everyone can see, observability. And that first requirement, relative advantage over what currently exists, is the necessary predicate to everything else. Think about it for all of us in our daily lives. Change is difficult. What compelling reason is there to do things differently? So I want to examine 2 safety improvement efforts, one that succeeded and one that sort of succeeded, but maybe not as much as they expected, given their core objectives. And I want to start with the story of anesthesia safety, which is often held up as an example of the profession making things better on its own. Next slide, please. So what actually happened with anesthesia safety? On April 22nd, 1982, the ABC News program 2020 ran an expose that was called The Deep Sleep. And the program began by declaring about anesthesia error, quote, this year, 6,000 patients will die or suffer brain damage, end quote. However, since this was TV, the statistic was accompanied by interviews with patients and survivors of real people, and who they referred to as, quote, tragic victims of a danger they never knew existed. Now, back then, the big 3 networks dominated the public information square. So that kind of expose on primetime television took care of invisibility. But as for professional inertia, in an interview in the Physicians News Digest in 2000, the anesthesiologist who'd been president-elect of the Anesthesia Society of America acknowledged that he'd been collecting data on anesthesia accidents for a decade. But after the program ran, they established a new patient safety and risk management committee, and the society eventually adopted the until then unpublished Harvard monitoring standards. So that self-motivation comes about through a pretty big kick in the rear. Now, as for income, and this is also important, not only were malpractice premiums, note the risk management part of that committee, soaring at that time, but, and this was not said explicitly, having the public distrust anesthesia is kind of an economic disaster if you're an anesthesiologist. And so today, anesthesia safety innovations are regularly implemented into practice, and safety is dramatically improved. And I looked this up. In 1982, there were about 100 deaths per million administrations of anesthesia. Today, it's 4. And of course, malpractice rates have gone down dramatically. Next slide. So let's talk to err is human. So that's something you're all familiar with. It came out in late November 1999. But now let's look at it in a different context. Let's look at it in comparison with the ABC News report, and let's look at it in comparison to diffusion of innovation. Because the point of the report, of course, is to cause medical practice to change, right? So first, hard evidence distilled into an alarming soundbite. Yep. Errors cost 44,000 to 98,000 deaths per year in U.S. hospitals. And the authors, by the way, I've had discussions with the authors, deliberately did this, okay? They wanted to capture public attention, okay? Point number 2, someone who was a trusted source, like ABC News was back then, sure, the Institute of Medicine, now called the National Academy of Medicine. And then, like TV, using stories of real people to make those statistics come alive. Yes, again, because in 1995, early 95, the Boston Globe published an expose about the death of a young Boston Globe columnist named Betsy Lehman. Betsy Lehman was a young mother of 2 who had breast cancer. She was killed by a chemotherapy overdose at Dana-Farber Medical Center. It was later discovered by a routine review of the records. Months later, the Globe did an expose, and it got incredible national attention. Young mother, Harvard-affiliated hospital, medical error, and newspapers and TV stations all over the country started running stories about medical error, which the To Err Is Human report took and used real stories of real people who had been harmed, who'd killed, the wrong leg amputated, the wrong arm amputated, or whatever. And that made this story come alive. And if you put all those factors together, and a bit of luck, because it was a slow news week, the public impact of To Err was so extraordinary that the President of the United States summoned healthcare leaders to the White House lawn to discuss medical error reduction. President Clinton then issued executive orders. There were congressional hearings. There were actions by state governments. There were pledges by professional groups. And as of July 1, 2001, the Joint Commission required hospitals to notify patients if they were harmed by a medical error. Okay. Now, again, public impact, you'll see, is one of my themes, right? So I showed you a New Yorker cartoon, which showed what the public really thought of doctors, as opposed to doctors today will tell you what they think people thought of doctors back then. Next slide, please. So the first cartoon on the left says hospital medical errors kill 98,000 Americans each year. And it has the patient being nervous while he hears them say, whoops, what the, dang it, my bad, uh-oh. And the second one shows a waiting room, and the doctor's holding something that says study medical errors are rampant, and patients are holding up signs. One that says this side up, mother that says measure twice, cut once, and the other where an older woman is wearing a sash that says perishable. And the comic strip Sylvia did some. There's all sorts of cartoons and comic strips that reinforce that the public is scared. That, my friends, is pressure. Okay, so as a result of all these initiatives, deaths from medical error plunged by 50% in 5 years, just as the IOM had called for, and disclosure of medical error to patients became routine in every hospital in America. Okay, as you can guess, I just made up that last sentence. The reality was that the pressure to change on any individual institution was not adequate to create relative advantage for change. Plus, the infrastructure to support change was lacking. So there's no question that Error's Human finally broke the silence about medical error. And yes, it's inspired both research and improvement, absolutely. But there's also no question that in the 10 years after to err, the evidence showed that the overall state of patient safety in America improved modestly or not at all. Next slide, please. So that report was authored by Dr. Donald Berwick, a wonderful writer and speaker. Now, Donald Berwick is head of CMS. And rather than making great speeches, he decides to commit $1 billion to essentially paying groups to help individual hospitals meet specific targets on reducing harm and make sure that they have absolute focus on what they're doing. As a result, you can see in just 3 years, hospital-acquired conditions down 17%, 1.3 million adverse events avoided, 50,000 patient deaths avoided, $12 billion less in healthcare costs because you've helped avoid unnecessary readmissions. Okay, all in a few years. And so when financial incentives stopped and government attention waned, the change in hospital culture continued, so that by the time the pandemic interrupted patient safety, deaths from medical error over 7 years had dropped by 50%, and disclosure of medical error had become routine in every hospital in America. Well, okay, I made that up again. They stopped paying them the money, and they stopped having culture change. This is extraordinarily damning, frankly, and nothing that we talk about in this context. So, just to recap, you want to stop harming kids with blood cancer, make sure it's profitable. You want to stop harming everyone, make sure it's profitable. All right, so given these lessons, these painful lessons of success and partial success, how do we create a relative advantage to adopting a patient safety culture that will motivate change, scale change, and sustain change? So now comes to the controversial part of the discussion. So there are 2 motivations for physicians and hospitals to undertake and sustain patient safety change. One is intrinsic, for instance, a patient death and the anguish it caused everyone on the staff, the impact of an article or a speech, or just plain dedication to making care safer. And the second motivation is extrinsic, right? That something happens. And so take a look at the next slide. This is intrinsic. This is fascinating. This is showing, of course, a physician who's devastated by what's happened. So the man on the right here, Armando Nahum, and a colleague, Marty Hotley, go around to hospitals trying to get them to do patient and family councils so they advise hospitals and keep care safer. Excuse me. They end up at Parish Hospital, Parish Medical Center in Titusville, Florida, and they're giving a talk about this in the staff room, right? And they look up and they notice that these guys have put up pictures of patients who've been killed by medical error. Not their patients, just patients from news reports, and the words "never again." And one of those patients, the one in the middle there, that picture, that's Armando's son, Michael. And so here at this hospital, which is one of the best that I've seen, committed to reducing medical error, they run across a picture of his son while they're talking to them. That, my friends, is intrinsic motivation. Next slide. Extrinsic motivation. This is the Leapfrog group, and you can be motivated by your Leapfrog score and reputation, by CMS requirements, by all sorts of things. And to be fair, every hospital in America due to extrinsic motivation, is now doing something to improve patient safety. So something is being done. And if we wait long enough, maybe CMS will tighten its penalties. Maybe there'll be some other actions. And that's the status quo, right? The status quo is that good people, if you want to support the status quo, good people are doing their best despite competing priorities. And thanks to their dedication and technological advances, safety is getting better. Okay. If you think that's enough, you can probably drop off this call, because the next thing I'm going to talk about is actual disruption, and not the Harvard Business School disruption of Clay Christensen, but the kind of disruption of policy entrepreneurs, Ralph Nader, or Mothers Against Drunk Driving. But one more question about the status quo before anybody drops off. There are about 4,000 hospitals that are general acute care hospitals. If 10% of them did everything they could to have zero preventable harm, not achieving the goal, but everything they could, that would be about 400 hospitals. Ask yourself, do you believe that 400 hospitals in America today are doing everything possible to have zero preventable harm? When I ask patient safety activists or clinicians or researchers that question, pretty much they laugh. Think of a number to yourself. So if the number you picked tells you the status quo is dangerously inadequate, then the next question is, how can we change it? Next slide. So how can we move the rock, right? For would-be disruptors to succeed, they need to direct public attention to the problem the same way that they do in other issues, right? High hospital prices, pharma, whatever. You have to be a watchdog ready to bark, and sometimes to bite, like legal filings. But now there is no individual group or individual person ready to take on this task. Patient safety researchers, not what they do. Quality and safety organizations, not their focus, or the revenues depend on the goodwill of hospitals. And you can't be a watchdog and bite the hand that feeds you. And that leaves patient-run groups, which range from solo efforts to a few modestly larger groups. And today, these activists do a lot of things. They work with hospitals and professional groups. They bring the patient voice to policy and coalitions and op-eds, and they do all sorts of work to influence federal and state regulation, legislation, and all of this usually completely not paid. But at a time when patient safety has vanished as a public or political concern, what patient activists have not done is pursued a tough-minded strategy that continually, constantly reminds the public and policymakers that not only isn't care safe, but those who should make it safe aren't doing what they should, and people are dying. And they need to create by not creating a competing narrative to the status quo, by not telling a different story, stories where people remember, by not challenging what should be challenged and demanding accountability, activists are implicitly allowing invisibility, inertia, and income to remain as barriers to change. And let me give you some examples. Okay, in 2021, as we were emerging from the pandemic, the Joint Commission issued a press release saying they were tightening their hand hygiene requirements. But their tightening still didn't require hospitals to set a goal, an actual numerical goal, or even implement surveillance, right? And where was a watchdog calling out this gaslighting of the public at a time when the public was very sensitive to infections, at a time when they could have told a story that the public would resonate with, but there was no watchdog barking, nobody calling this out. And by the way, whatever happened to the Joint Commission requirement that I talked about earlier, that hospitals are supposed to inform patients of medical error? Where's anybody calling them on that? Yes, patients should be able to report error. That's our focus now. Where's anybody calling out what was promised to be done and isn't done? Okay, number two, research last year by Professor Dykes and colleagues in JAMA on falls. Okay, I love this. Patient falls in hospitals are, quote, the leading source of non-reimbursable adverse events. Sure, because those are the worst type, right? So the researchers went on to present a cost-benefit analysis of why hospitals should spend 88 cents per bed to prevent unstable patients from falling and hurting themselves or dying. Where this was like in a major publication. Where is the watchdog group indignantly pointing out how outrageous it is that we need income-related plea to stop falls? Where's somebody providing journalists with people from our group who fell or their loved one fell and hurt themselves or died, and thereby also opening up the larger topic of profitability of adverse events, a powerful story that nobody is telling. Example number 3. I talked about the update of the Harvard Medical Practice Study that included, remember, 1 in 4 patients are harmed. Well, the Wall Street Journal used that finding as a news peg to write a story about patient safety. Great, right? Except the story said hospitals are using technology to prevent harm. That was what it went on to say. Hospitals, as if it were common. Now, I assure you that the reporter, who was a veteran reporter, wrote that because there was no advocacy group providing a balancing narrative. Nobody to say that, no, it's not all hospitals, it's a few hospitals. Nobody to bring patients to tell stories of harm. Nobody to tell vendors to say, you know what, I can't sell this stuff because it's not profitable yet. Instead, we get the Wall Street Journal, one of the most influential news organizations in America, telling a false story because there's no watchdog telling them what the right story is. And this, I can go on these. There's so many examples, but the key is on the grassroots level, there's nobody doing what needs to be done, speaking up about morally awful stuff. Like, for instance, last example, the Centers for Disease Control and Infection is trying to prevent CLABSIs. Dr. Peter Pronovost did it in 90 days back around 2013, 2016, something like that in Michigan. CDC is giving them years and years and years and years, and there's no watchdog saying, what is going on here, people, while people are being harmed? We're just not out of it. Now, on the grassroots level, we can start to go to hospitals. When the Leapfrog group comes out with its ratings, we can have patient groups that go to the hospitals that are good and talk to their board, and go to the hospitals that are bad and talk to the hospital board. There's all sorts of things we could do that we're not doing. That's not the kind of activism. Again, Mothers Against Drunk Driving, the gun control people, all the other people. If we believe people are dying, let's act that way. Now, I'm not criticizing any individual or group because we all do what we can do. And you know, patient work is time consuming, emotionally exhausting, mostly unpaid. But there is a reason negativity works. There is a reason people run negative political ads and other negative ads, because negativity is what we as people are evolutionary trained to avoid, right? So that's why people care about the high cost of medical care or about health insurance, because if I don't have good health insurance, if I can't afford care, I could be harmed. But thank God, once I get into the hospital, I'll be safe. Once I get to the doctor, I'll be safe, because they don't know any differently. We haven't told them. If you remember only one thing I tell you this morning, please remember this: your caring about patient safety matters. Your caring really matters. This group, when individuals and organizations are motivated to change, you all are the role models. You all are the guides. You're the people, the supporters who show compatibility with existing values, that things can be done, that the results can be seen, that it works. You are the people who can turn intent into implementation at the front lines of care. Why do we still kill patients? Because invisibility, inertia, and the insidious influence of income have created a culture of see no evil, hear no evil, fix no evil. We have failed as a community to eradicate the excuses and evasions of we don't need to change, we can't change, and we shouldn't change. Yet we can change. Us who care about this, who are passionate about this, can overcome with your help, but we shall not overcome until we commit to a change strategy that reflects political, social, and economic reality. The next slide, please. I want to close by reemphasizing that your caring about patient safety matters, and by adding an exhortation from the novel Le Petit Prince, The Little Prince by Antoine de Saint-Exupéry. As for the future, he wrote, your task is not to foresee it, but to enable it. And that, frankly, is why I am so grateful to be here. Last slide. Thank you so much. And now you can all look at your phones. Thank you so much.
Well, thank you so much for the excellent and thought-provoking presentation, Michael. I'm so glad you'll be here to champion for the patient safety for both patient families and for the healthcare providers. So your expertise and insight have generated, I hope will generate lots of questions from the audience, and you won't mind to answer a few of them. Here I have one comment, really powerful talk. Thank you for the inspiration. So that someone just posted it.
Appreciate it.
And there's a question. You mentioned a lot in your talk about invisibility. And what is your thoughts on the number one solution? You know, we face all kind of difficulties right now, staffing and shortage in funding. So also transparency have traditionally is a big issue in healthcare. So if you just gave one solution, what do you think it would be the key?
Well, there's two kinds of invisibility. One is the invisibility to the public, and the other is the invisibility within the healthcare institution itself. Within the healthcare institution itself, there's absolutely no doubt whatsoever that it's the leadership, right? Are we willing to hear and see bad news and empower people to report what they see, both the staff and if necessary, the patients, and make the invisible visible? Because, you know, people respond to what they can see, and the intellectual idea that people are dying preventable deaths is not the same thing as actually being able to see it. MedStar's Washington Hospital Center did something which was actually piloted by a woman at Mayo Clinic, something where after every death, even if it was just a routine kind of thing, they had a committee that was not just from that department, but throughout the hospital, look at the death and say, what can we learn from it? And sometimes they found preventable medical error, but other times they just found things that could be done different or better, that somebody could be transferred, somebody could have a different therapy. It just improved medical care. They looked at every death as an opportunity, and rather than having the department review and saying, yeah, we did everything right, they reviewed it in a continuous quality improvement context from inside. And so leadership that sends that message, like you saw putting up at Parish Medical Center, never again, right? That's a pretty powerful message, even though it's not your patients. From the outside, there's got to be a watchdog. I mean, statistics, we live in a world where there are lots of problems, right? And I'll give you the example. We all know that the infrastructure in America is crumbling, and yet we really don't do anything about it, even though all of us drive on highways and bridges and, everything else is the infrastructure. But when a bridge collapses, that gets our attention, right? And so when I talk about there being a watchdog, that's about transparency for the visibility, is that even if there's a study that says falls, to point out 88 cents per bed, we're still asking for that, really? And then have someone who was a victim of a fall, which God knows there are plenty, talk to the journalists. We need to make people in the public feel that they're, but for the grace of God go I, right? Because when you see studies about someone who went to went to the hospital for a splinter and they come out with a $8,000 medical bill, you go, oh my God, that could be me. Or somebody who can't get care because they wait in the emergency room for hours, that could be me. We need to make patient safety and medical harm, again, an issue where the public says, that could be me. And at the same time, we need to change financial incentives and enable people to change. So those are kind of the two things: provoke change and then enable it with what comes underneath through your kind of work or others.
Yeah, thank you. We have only one question left. There are lots of praise for your admiration
Thank you.
for your work. And there will maybe just one more question for the time remaining. Speaking of invisibility, ambulatory patient safety, clinical medical groups seems to be less of a focus of a patient safety world than hospital inpatient. Do you know of any group focus on ambulatory patient safety?
Ambulatory patient safety has been ignored, and people saying, why are we ignoring it, for years and years and years. And occasionally now I've seen one or two articles, and that's about it. Now, partly that is because of the severity, and partly I don't know, but it's a great question. And considering how much of care is now done in the ambulatory environment, it is bizarre that it's barely gotten attention. So I wish I could be more optimistic than that. And by the way, I put my email up there, so I'm open. I understand we ran out of time. Feedback is always welcome, and I'm happy to engage in a dialogue with anyone who feels that they would like to do so.
Yeah, they're great. And I think we are about run out of time. So I just want to thank you so much for your great presentation, and also thank everyone for attending today. And if you have any questions, email Michael, talk to him directly, and you will get his great resources on patient safety and inspiration. So our next session we started at 9:15. So actually we have 2 minutes left. Maybe I can get you to do one more. Would you mind?
Sure, happy to help. And you can share the chat with me later if you like, or whatever. Go ahead.
Yeah. What practical strategy would you recommend for patient safety committee to ensure that meeting consistently to actionable improvement rather than just discussion? So that would be short from your answer.
Oh, look at actual incidents in the hospital, and use root cause analysis to say what could we have done differently, and make sure whatever you find diffuses throughout the hospital. There's lots of changes that people make that sort of peter out. Find specifics, because people respond to specifics, change those specifics, and make sure that you institute those changes as something that is the way we do things. Very quickly, no surgeon is allowed to operate without wearing a gown, even if they brought in a tuxedo and said, look, I just dry cleaned it, and my grandfather was a surgeon, I'd love to wear a tuxedo. We don't let people do things saying, well, it's okay. We have ways we do things. That is the way we do things to keep it safe, and we don't make exceptions. Take what you're talking about and start to do bit by bit, little things by little things are big things. This is how we do things to keep people safe.
Okay, great. Again, thank you, Michael, for
My
excellent
pleasure.
presentation. And thank you everyone for your attending and great questions from audience. Email Michael if you can and have a direct conversation. Thank you all again.
Thank you.
Thank you.